Yeah, I'm just going to say I'm delighted to be joined today by Dr. Mona Osman Al-Haj for this health science talk series. I'm just going to make sure that to have kind of a couple of reminders before we start the session. This session will be also hosted online, and the session will be recorded for later on if you want to kind of share the materials. I would just going to ask those who are joining online to please mute your microphone. And we're going to have plenty of opportunity towards the end of the session, almost 10 minutes after the presentation, for Q&A. So they could kind of post their Q&A in the Q&A function, and Dr. Salim would kind of voice their questions. So I'm just going to introduce our presenter today, Dr. Mona Osman Al-Haj, an assistant professor at the Family Medicine. She's also the medical director of the Family Medicine Clinics, the coordinator of the community and outreach activities, and the director of the Fellowship of Primary Care Sports Medicine and the Department of Family Medicine at the American University of Beirut. She's also the director of the University Health Services and the co-director of the Refugee Health Program at AUB. Dr. Osman is the head of the training committee of the Scientific Council of Family Medicine at the Arab Board of Health Specializations, leading the implementation of the Regional Professional Diploma in Family Medicine. She's also the president of the Lebanese Society of Family Medicine. Dr. Osman founded the CHAMPS Fund, the Hisham Al-Haj program for young hearts and athletes' health in memory of her son Hisham, to help save the lives of youth from sudden cardiac arrest. So Dr. Osman will present us today about the sudden cardiac arrest, SCA, the most common cause of preventable death among young athletes. This presentation will discuss the burden of SCA, and namely among the youth, and highlighting the latest recommendations for the screening and early identification of predisposing conditions. This will also cover the immediate measures that need to be taken when facing a person with SCA. Without further ado, Dr. Osman, the floor is yours. Thank you.
Good morning, and thank you very much. So I'm very happy to be here today. I'm a graduate also of the Faculty of Health Sciences, so it's a pleasure to be at home again. And what I will be talking about, thank you, Dr. Samar. So as Dr. Samar mentioned, so I will be presenting about sudden cardiac arrest, what is the burden of sudden cardiac arrest, especially in young people, what are the main causes for sudden cardiac arrest, and what can we do really to prevent that. And while doing that, we will state what are the latest recommendations for screening for sudden cardiac arrest, and what can we do when we face a person in sudden cardiac arrest. So to start with, I think a lot of you have heard about, young professional athletes who maybe who collapsed while playing their sports. I would like to start with a short video just to show you what do we mean by sudden cardiac arrest before going to the presentations. And this one is where it is. No, not this one. I think this is the first video. Yes, this one. So the one in red is the Miklos Feher. He's the player. And as you can see, in 1 minute, he fell down, and that was it. He passed away at a very young age. So let's go back to what is, in fact, sudden cardiac arrest. So sudden cardiac arrest is the, if you want really the definition, is the sudden cessation of circulation that is mainly caused by a cardiac arrhythmia. So this is an electrical problem as compared to a heart attack, which is mainly a circulatory problem. So those who will have a heart attack, they might have a chance to survive because maybe one vessel is blocked, but they have other vessels that are there. Sometimes they might go into arrest if it is really a big, a big vessel and a big area of the heart that is affected. But as opposed to those who have face sudden cardiac arrest, this is an electrical problem. The heart will stop working correctly because of arrhythmias, which can mainly be ventricular fibrillation or ventricular tachycardia. What do we define sudden cardiac death? Because sometimes they are interrelated, and sudden cardiac arrest can lead to sudden cardiac death. So it is mainly the sudden natural death that is presumed of cardiac cause, which occurs 1 hour of onset of symptoms when witnessed, and within 24 hours of last being seen alive, and it is contributed to a cardiac cause. So what is the burden of sudden cardiac death and sudden cardiac arrest? So it is estimated that the annual burden of sudden cardiac death worldwide is around 4 to 5 million cases every year. This is not only in young people, and this is all age groups, okay? So it is thought to account for roughly half of all cardiac death and about 15 to 20% of overall mortality. And in fact, it is the greater burden of premature death, even when compared to all cancers together in a way. So as you can see in the picture, the number of people affected by sudden cardiac death is even the accumulation of all types of cancer causing death. So what is the burden of sudden cardiac arrest in youth? So the incidence of sudden cardiac arrest varies between 0.4 to 3.6 per 100,000, but this is depending on the population that is studied. This is depending on the athletic, status, depending on the age of the individuals, and it is considered as the leading cause of death in young athletes, aged 12 to 35 years of age. The incidence can go as high as 6.8 per 100,000 among football players, and it is 2 to 3 times more common in athletes as compared to non-athletes, but it can happen everywhere. It can happen at all ages. It can happen to children, teens, and young adults, and it can happen even at a sedentary, at rest, when people are sleeping, and at recreational activities. If we will go by the numbers, maybe it is not that very common. I mean, in youth, it is not that very high, and the incidence. But of course, this is tragic when you use a young athlete or a young person suddenly suddenly without knowing. So the epidemiology of sudden cardiac arrest is more common in males as compared to females, 30-folds. It is more common in Black as compared to white athletes, and it is the most affected players are mainly the basketball and football players. Is exercise bad? Of course not. This is not a message that exercise is bad. Of course not. Physical activity is and remains an integral component of the prevention of cardiovascular disease, and it can protect, of course, from cardiovascular diseases. But sometimes vigorous exercises in persons who have already a cardiovascular disease or a heart problem, yes, it can be a killer. Okay, so that's why it's very important to really discover these heart problems before they can cause sudden cardiac arrest. So what are the main causes of sudden cardiac arrest in youth? We can divide them into 3 categories. One category is due to a structural heart problem. The second one is electrical, and the third one is acquired. So the structural heart problems, for example, like hypertrophic cardiomyopathies or mitral valve prolapse, or aortic stenosis, these are common sometimes among the population. Electrical problem, like, for example, the Wolff-Parkinson-White syndrome, long QT, short QT, all of these. And also we have the acquired, and this is something that we cannot discover beforehand, but this is something, especially from a public health perspective, we can really raise awareness regarding that. So one of that is infection that might cause a viral infection that might cause, for example, myocarditis. And this is what happened with, for example, COVID, because in COVID, during COVID, the number increased of young persons with myocarditis and those who maybe passed away. Trauma, which is commotio cordis, for example, a strong hit to the chest sometimes can cause a sudden cardiac arrest. Performance enhancing drugs, and this is where our role is mainly هول المنشطات, يعني what the young take to the gym and while playing sports to become stronger, more fit, and to do bodybuilding. مثلا. Some of these drugs they can lead to sudden cardiac arrest. And of course, the final one is the environment in terms of hypothermia or hyperthermia. However, unknown causes can be in 40% of the cases. The most common in children, adolescents, and young adults are the primary arrhythmias, myocarditis, and the cardiomyopathies. And primary arrhythmias and cardiomyopathies, some of them are really, they have genetic causes, and they can be hereditary, so they can move in the families. And that's why whenever there is a person who is affected by sudden cardiac arrest or sudden cardiac death, it's very important to know what's the cause and to screen the members of the family for that. Why it's important also to maybe screen or do something about these diseases. And you might say, and why do we need to discover them beforehand? We can discover them beforehand because there is management, there is treatment. Sometimes the treatment can be just a pill. Sometimes it can be an ablation, like a simple procedure. Sometimes you might need surgery. Sometimes you cannot discover the cause for that, and you can have an implantable cardioverter defibrillator, which will give a shock whenever there is a sudden cardiac arrest. And this can save also the life of a lot of people who have it. So the prevention of sudden cardiac arrest and sudden cardiac death is really depends on awareness, depends on screening, and depends on resuscitation whenever there is or the arrest will happen. So awareness, why awareness is important? Because the death can be the first symptom that a young person can have for a cardiac condition. So that's why it's very important always to raise awareness among the youth about symptoms that can maybe sometimes it's very common and we take it very lightly. But I think we need to reconsider that and not take lightly, for example, a chest pain upon exertion, or sometimes if they faint, there is for unexplained reason, or they feel they are near fainting when they do exercise. Or if there is a racing or skipped heartbeat, for example, or if there is an excessive fatigue or a fatigue that is different from before. And whenever they are feeling that, they have really to go and check, with the doctor to see what's the reason for that. People who can be also at risk if they have a high blood pressure that is not well controlled, or if there is a heart murmur that they don't know what's the reason for. Sometimes if you know most of the murmurs, sometimes they can be physiologic, and they cause no harm, but there are some that you need to follow up. Of course, also if there is a family history, because as I mentioned, it is genetic, it is hereditary for some of the cases. So it's if there is any premature death in a family member before the age of 50, or if there is any family member who have a heart condition before the age of 50. The second component is screening. So by screening, what do we mean? By screening, we mean to do tests or some interventions in a way to discover who is the person who is affected with the heart condition and who is not, for example, and those who are affected to advise them, maybe to give them advice or to give them the medication or etc. Okay, so the cardiac screening programs, in fact, they started early for athletes. I mean, for young athletes, it started early in 1970s, 1980s, and with this program where they added the electrocardiogram to the screening among the Italian professional athletes, they found that over several years, they were able to reduce the sudden cardiac death incidence by 89%. And that's why, following that, EKG was introduced as one, if I can say, one of the elements that we need to use to screen for sudden cardiac arrest. What's the detection rate? What's the detection rate of potentially lethal cardiovascular diseases? It ranges between 0.3% to 0.4%, depending, of course, on the setting, depending on the people who are screened, and depending on the used test to screen. So, what are the components of the cardiac screening? Usually, we have a history, a physical examination, and an electrocardiogram. So the history, this is what the American Heart Association, the 14 element of the American Heart Association recommend for the history and for the physical examination. And for the history, they are the same that I mentioned in the symptoms to a certain degree. So you need to check with the athletes in the pre-participation examinations or with the youth if they have any of these symptoms. Of course, any family history. And in the examination, it's important to check the heart, the blood pressure, and to check other, stigmata or, for example, symptoms or physical findings that can show that there is Marfan syndrome. There are controversies regarding that or arguments against or for physical examination and history. The arguments for is that medical history and physical examination are, are part of what a doctor should do in a way in the clinics. And they are inexpensive, in fact, and taking a history and doing a physical examination, they are inexpensive, okay? But arguments against is that they have a low sensitivity, a high false positive rate. The questionnaire, sometimes those that I showed you, they are built or based on expert opinion, and they might differ in different socioeconomic and different societal factor conditions. And of course, they require honest reporting from the athlete or from the youth. The arguments for the EKG or against the EKG. So for the EKG will increase the sensitivity and specificity. It is an objective test, and it is evidence-based, the reading of it. Those against, because there is a higher percentage of false positive rates in some cohorts. And also there is potential of false negative in certain conditions, like, for example, if they have a coronary anomaly, coronary problem, because you cannot detect it by EKG. The problem with the issue of the false positive is because of the reading of the EKG. But with time, they refined the reading of the EKG, and with time, the rate of false positive decreased with the refinement of the reading of the EKG. The third part is regarding the cost of screening. And the cost of screening, the available studies that did the cost-benefit analysis, they focused on the cost associated with history, physical exam, and EKG. And also they were different because it was different population that is studied, so it did not really, it is not very conclusive. But I put here some examples of the cost of pre-participation examination, including the EKG in certain countries. Like, for example, in Italy, it will cost 30 euros, 20 euros to 30 euros if it includes the EKG. In USA, it might cause the cost to do the EKG history and physical examination might rise to $89 per athlete. In UK, it dropped with time with the changes in the EKG reading, okay, in the EKG interpretation. So some of people might consider that this is high, especially if you want to do a universal screening for every youth. So can we consider that we have an ideal screening test? If we know what are the characteristics or criteria to have a good screening test based on WHO, these are the characteristics. And it should identify a disease that is clinically significant, yes, because the outcome of sudden cardiac arrest is death. Prevalence warrants testing in an apparently healthy population. Yes, prevalence is not high, but as I mentioned, the outcome is to a certain degree painful. It must be for a disease that has a preclinical phase, like, for example, we do the mammography for the breast cancer because it is sometimes asymptomatic. And this is in sudden cardiac arrest. Also, there are no symptoms in around 80% of the cases. And the disease must have an acceptable treatment course. Treatments are available, as I mentioned before. It is non-invasive. All the tests are non-invasive, whether the history, physical exam, and the EKG. And it is the sensitivity and specificity are acceptable. And we remain with the price. And this is where really we want the challenge. And this is where the issue is if we want really to go with a universal screening for that. So what are, taking this into consideration, what are the recommendations of scientific societies? So the American Heart Association recommends the use only of history and physical examination, okay? And this is the same recommendations by the American College of Sports Medicine and the American College of Preventive Medicine. However, in 2015, they made a little bit of change. They introduced EKG, but it is only in cohorts of young, healthy people, 12 to 25, who are supported by adequate expertise and resources in reading the EKG. Okay, so if these are available, then yes, they would recommend, yes, do the EKG in addition to the history and physical examination, but they are still against recommending for universal EKG screening. The European Society of Cardiology, the opposite, they recommend to add EKG to the clinical examination and the physical examination, and this is based on the experience of Italy. This is since 2005. And this is the most recent recommendation, which was done by the American Academy of Pediatrics Task Force in 2021. They recommended that, yes, we should screen all children, athlete or not, in the course of their routine care and or pre-participation examination. By children, and I mean children, adolescents, and teens, and young adults. And what does this include? A thorough and detailed history, family history, and physical examination. And if there is a risk, or if you suspect that there is a risk for sudden cardiac arrest, then you would do the EKG. Okay, so the EKG also, it should be interpreted by a physician who is trained in, reading the EKGs, whether a cardiologist or electrophysiologist or etc. Okay, and they recommended to have these screening questions, which are mainly the symptoms that I mentioned, so I will not read them again. So to have these mainly asked by every pediatrician, family physician, general practitioners who is seeing a child or an adolescent in the clinic, okay? So you need to ask for these questions, and if there is any positive response, then we will do the EKG. So what is the frequency of this testing or screening? Is it one time? No, it's not one time, because there are some cases that might not be evident at one point in time, especially if it is done, for example, early at 12 years or 13 years, especially for hypertrophic cardiomyopathy, because sometimes this develops with time and you might not be able to catch it at one time in the beginning. So that's why the AAP also recommends that this should be performed at a minimum of every 3 years, or into when you enter a middle or junior high school or into high school, okay? Depending on the family, of course, and the primary care physician, maybe more frequent screening should be done. And if they suspect something, maybe they will do it every year. But there is no need to do it really. It's not, you should not do it just once, especially for the adolescents in a way. And this is another, there is a study that also proved that there is a lack of efficacy in a one-time EKG screening, because they mentioned it might be effective in identifying electrical diseases, but it cannot really detect one time the cardiomyopathies, and it requires serial assessments. Controversies, as you said, as you've heard, controversies are still there. Because there is no randomized trial that has shown a mortality benefit from the screening. False negative tests, they might provide false reassurance to athletes. Sometimes you might have false negative tests, especially, for example, if the condition, as I mentioned, is in the coronary arteries or other conditions maybe. False positive tests might have significant problem, psychological stress, for example, or might have significant problem at the level of the insurance coverage, at the level of, for example, joining professional teams, which can affect the scholarships, etc. So, and it can affect, of course, the mental health of the athlete, of the young person, and the family at the same time. And also the cost, as I mentioned, any form of screening can lead to significant costs at the level of the healthcare system. Again, screening, as I mentioned, cannot detect all causes of sudden cardiac arrest. So, as I mentioned before, some causes can be acute, like commotio cordis. Some cases cannot be detected by the usual screening, like, for example, coronary artery anomalies. They might need a cardiac MRI, or sometimes even the EKG can be normal in 5 to 10% of young people with hypertrophic cardiomyopathies, and 25 to 30% in individual with long QT syndrome. Maybe repeating the test several times in these cases can help detect these conditions. So what's needed? So we said we need to raise awareness. people should know what are the symptoms and what they should do if they have these symptoms. The second is the screening. So this is to detect the primary screening, if I can say, so to detect the conditions beforehand. And if we cannot detect it, or for example, for acute cases, and suddenly you have a sudden cardiac arrest that happens in front of you, then cardiopulmonary resuscitation and the use of defibrillator is the key. Why? Because as you can see in this graph, here it's the time collapse to defibrillation using the AED and the automated external defibrillator, and up you can see probability of survival. As you can see, at 5 minutes, the probability of survival is still okay. As you go 10 minutes, it decreases. Later on, it will become almost zero. So every minute, a person in sudden cardiac arrest will lose 7 to 10% chance of survival. Okay, so that's why it's very important whenever we face a person in sudden cardiac arrest. What do we mean also by sudden cardiac arrest? This means that he's not responsive, he's not breathing, and there is no pulse. So we need to start immediately the cardiopulmonary resuscitation, CPR, in less than 1 minute. And also we need to give the AED, the defibrillation, in less than 5 minutes. And this was found to triple the chances of survival in persons with sudden cardiac arrest. So this is also, you can see the chain of survival. And this is the important role that the recognition and the initiation of response and the immediate high quality CPR with defibrillation. All this part, and the first 3 rings, if I can say, they are at the level of the public, at the level of the bystanders, the level of every person among us. So this is what really we can do whenever we face a person in sudden cardiac arrest. Later on, the emergency medical services and the hospitals, they will play a role in saving the person. The survival rate, unfortunately, is low worldwide. It is mostly under 10%. Yani for the sudden cardiac arrest that happen outside the hospital. And however, in some settings, the survival rate can reach up to 80%. So this is depending on the setting, if they are well-trained, well-equipped. At AUB also, we have defibrillators that are placed in different areas with signs to that. But I think with time, maybe awareness was lacking regarding what to do and, where the AEDs are available. But hopefully, it is being resumed, inshallah. So in Lebanon, there are very few studies that are done regarding the out-of-hospital cardiac arrest. But one of these studies have shown what's exactly the survival rate. And the survival rate in the study, it was 4.8%, and in another study, it reached 5.5%. So this is what we have in Lebanon. And even as you can see, the practice of CPR, and whenever there is a person in sudden cardiac arrest, CPR done by EMS, it was only in 43.2%. This is a study done at AUB-MC. And CPR done by family or a bystander, it was 4.4%. And the use of automated external defibrillator was 1.5%. So that's why really the survival rate is really low. And only among those who survived, 53.8% had a good neurological outcome. Because again, with time lapsing, the brain will not function adequately with time because of lack of oxygen. And in Lebanon also, that's why it's really important to have people who can really start CPR and use the AED whenever faced by a sudden cardiac arrest, because even our emergency medical services to arrive, it might take more than 10 minutes or 15 minutes because of the traffic and all of this. I found this, while preparing for this session also, I was happy to see that the Lancet, there is a commission on sudden cardiac arrest in the Lancet. And this was, published in September, this September. And I like this, this graph because it shows this is the chain of survival that I mentioned. This is what is the effect, which part of this chain has more effect on the survival of the person in sudden cardiac arrest. And as you can see, the highest effect is in the first three. Yani, this is where we ourselves can act. Yani, every person can act. But if you want to see what is the percentage of grants that is given for research, and it is the minimal part is given here, the highest part is given at the level of the hospital, which is not the most rewarding part in a way. So this calls maybe for more research, more funds, more grants to work at the first three levels. Also, when we talk about asking regular people or bystanders to maybe intervene whenever there is a person in sudden cardiac arrest, always there is the issue of the medico-legal. Shall I be prosecuted, for example, if that person died and did not survive, or do I do more harm to that person if I intervene, or better not to intervene? There is in Lebanon, we did not have before the Good Samaritan law. We had this القانون in Arabic. Can I read it in Arabic maybe? لأنه هذا القانون اللي هو 567. So من وجد بمواجهة شخص في حال الخطر بسبب حادث طارئ أو بسبب صحي وكان بوسعه إغاثته أو إسعافه بفعل شخصي أو بطلب النجدة دون أن يعرض نفسه أو غيره للخطر وامتنع بمحض إرادته عن ذلك يعاقب بالحبس. So it was a negative rewarding. It was not a positive. يعني it was they will be put in jail, or they will be asked to pay a fine if they did not help. So there is a group, I think, that was established at AUBMC and with collaboration with different NGOs working in this field and stakeholders, and it was led by Dr. Hussein Ismail at that time, Dr. Samar Nuruddin also, and we were part of it, where they worked with the parliament to make some change to this law, and to turn it into a Good Samaritan law to a certain extent. So what was added is this one: لا تترتب أي مسؤولية على من باشر بتقديم الإغاثة أو الإسعاف، لا سيما للذين يتعرضون لتوقف عمل القلب عن طريق الإنعاش بصدمات كهربائية أو ما شابه، حتى لو لم يفضي تدخله إلى أي نتيجة. Okay, so I think this is to reassure people. Really, you can save, if you want, you can save the life of a person. I would like to end a little bit on maybe a person, but just to give you more, to show you the difference, if I can say. So this is Hisham, this is my son. His birthday was 4 days ago, and he was born on November 11. And Hisham, he did not make it. Hisham, he had a sudden cardiac arrest at the age of 15 when he was playing football with his friends, and he had a sudden cardiac arrest. We did not screen Hisham before because he did not have any symptoms, and they did not use. They started CPR at the time, I know, but they did not use AED at all. There was no AED. But as opposite to Hisham, you can see that screening and using CPR and AED can save life. And this is the example. Again, it's not, the story is not only Hisham's story. We have a lot in Lebanon who really lost, young people who lost their life, whether athletes or not athletes, to sudden cardiac arrest. But you can save a person's life. So this is a student. His name is Hassan. You can be as Hassan. Hassan had a screening for his heart, and a condition was discovered, and an ablation was done because he had WPW, and he's doing well. He's able to play sports. This is a message that we received from his mother. So Hassan did the screening and he survived. And another, this is an AUB student. I put his photo because he did on YouTube. I think there is the video connection. I will put it at the end, maybe, if you want to hear it, because he shared of his experience. So he was an AUB student, and on December 18, 2018, he had a sudden cardiac arrest in Hostler while playing volleyball, I guess. But these heroes, they were the coaches at AUB Hostler. They recognized that he had a sudden cardiac arrest, and they started CPR and they used the AED, and they saved his life. And here he is in I think it was last year, when he was sharing his experience in Turkey in one of the meetings. So yes, we can make a difference. Maybe at the level of the individuals, yes, maybe not at the level of, if we want the public and the perspective, but you can make a difference if you do the screening and if you learn how to do the CPR and AED and use it and you have that available. I want to share just these memos in a way, if I can say. These were issued in 2019 by the Minister of Public Health, urging schools, urging sports facilities to have AEDs in place, for them to have people who know how to do the CPR and use the AED, and also to conduct the screening for the heart, for the heart conditions among the youth. So these memos were issued at that time in 2019. Also, there is in the school health program a chapter in the medical examination book on how to do the screening for young athletes, including all these questions that we mentioned and the EKG. And also this is a memo again that was issued by the Minister of Public Health in 2019, stating that AED should be available in all public places. Unfortunately, what happened after that is, we know all the economic crisis and COVID and everything, which stopped, I think, all these steps to be done. So what are the take-home messages? I think despite all controversies related to screening and the modality of screening, prevention of sudden cardiac death and sudden cardiac arrest in youth and young athletes is feasible. Awareness is key. Ensuring primary and secondary prevention through the use of CPR. And whenever any person is in sudden cardiac arrest, CPR and AED, this will ensure success. EKGs, yes, they might, the EKGs can detect pathologies that history and examination cannot detect, but maybe it should be, because of, you should consider the financial resources, you should consider the setting in a way. So shall we do to everyone, or just to athletes, or those who have risk factors, or those who, for example, have family history, who have sudden cardiac, or who have sudden cardiac death or heart conditions? This, I think, it needs to be discussed, and these are questions I'm raising. I think the last three ones are mainly issues that I would like to put on the table, especially from a public health perspective, I think, and we can do a lot for this, whether to say an EKG should be done to which category of people. Research is really needed to have more strong, ground for recommendations. And I think we need more advocacy and action on what has been done so far to be better prepared for sudden cardiac arrest. Thank you. You want me to show you, I want to show you just maybe two, we still have maybe 3 minutes before we'll... So this is an example of how this is a student in the US. She was also playing football. You see how she fell down, but she was, this is Claire, she was lucky because they started immediately CPR and they used the AED. You can see they gave her the shock there. And she survived after 4.5 minutes, I guess. And the emergency medical services, the EMS, they arrived after 11 minutes. If they waited for them, maybe she could not have been saved. So this is the example of that you can really make a difference. And this is a story of, it's a bit long, I guess, but maybe, or I can leave it for you to see it later on, Mahek, if you want. But this is, Ili, let me see where, yeah.
My name is Ili Boisa. I am here today with you to share a real-life testimony of how one of your devices has saved my life. I'm a 24-year-old Lebanese guy who came here to basically thank you all for your hard work for what you're offering us, and we're literally saving my life and giving me a second chance. And what brought me here today is basically Vanina and Muhammad reaching out due to, of course, knowing about my story, and Muhammad was key player in that
So
story.
Muhammad is one of the coaches who saved his life. So I will stop it here. Anybody, if you're interested, I can maybe share the link later on.
Yeah.
Okay, thank you. So ready for any questions?
Thank you so much, Dr. Osman, for this
Thank you.
eye-opening and resourceful information that you provided. And as you said, I know there's like a lot of prevalence of the cardiac arrest among the population, but I think one life lost is one too many. So, and I'm actually pleased to work with Dr. Osman. We're joining efforts to work with within the MHPE Eye Care program on providing training for schools for concussion as well as AED. So this is a part of the awareness and preventing of all these tests. Okay, so I'm just going to open the floor for any questions. If you have any questions, and also same thing for the online. Online? Okay, let's start with the online.
So we have Ms. Batul Shannan. She's saying, thanks for the great talk. Can you comment on the effects of psychological condition of a person and whether gender plays a role? We usually only hear about males.
Anyway, gender plays a role. It's more frequent among males. Yeah, this is what the studies have shown. Maybe because I think sports was more common among males traditionally. So that's why currently they don't know really. Even in this Lancet review, the Lancet Commission review, they mentioned it is 30-fold more common in males as compared to females, but they don't know why it is more common. And they suggested that more research be done to really know why it is more common among males than females. So I don't know why it is more common among females. So what was the first question? Come in. That's it, Mahek. Okay. It will not cause a sudden cardiac arrest, the psychological. For example, of course, stress might cause a problem later on in life. It might cause at the level of the blood vessels later on in life, maybe, and can cause a heart attack, but it will not cause a sudden cardiac arrest for sure. Okay. Yes.
Thank you, Mona, for a very enlightening talk on a very sensitive issue. I'm wondering, what is the likelihood of this recurring? For instance, the video that you have showed us for the young person talking in, yes, Claire and the other person. What is the chance of this recurring, and what should be done to prevent this from recurring?
Yes, so this is depending on the condition. So the underlying condition. For example, if it is a WPW, for example, that you do an ablation for it, you're treating it. So there is no chance of recurring unless there will be a similar problem later on, but there is no chance of recurring. But for example, in some of the cases where they don't discover really what is the condition, or maybe in hypertrophic cardiomyopathy that is very severe and without maybe, treatment that is given. Usually when this is the case, they will put an ICD. So this ICD will work to protect, if there is any second sudden cardiac arrest that is happening in a way. So it will give the shock and it will treat it. So it depends on the conditions, on the underlying condition and the treatment that is given in a way.
So because some people do not show symptoms, so the best recommendation in this case is treatment rather than screening? Screening. I know screening, but screening is very expensive and it's very costly, and it may not really be that widely adopted, especially in low-resourced countries.
Yes.
But we could train people who are
on CPR and AED, of course.
Yes, on this, and especially that people do not. If people showed symptoms, then they would be screened, they would be treated, and etc. But for those who did not show any symptoms, then probably we need to push
This is the
for
solution.
an intervention
True.
for
Yes.
rescuing and for primary.
So here we have three bases for that. So we have the awareness to let people know and what are the symptoms if they happen, in case they have them, what things they should avoid. For example, the performance enhancing drugs, excess caffeine sometimes can cause that. So this is the awareness. The second, if I can say, part is the screening. And the third is CPR and AED. So raise awareness and train as much as possible. Even with the, even, you will see, we will have, maybe Dr. Samar also will mention it now, but you will have the chance to see the CPR and the AED outside and to be trained on it. But even CPR can really make a difference, even if you don't have the AED, because AED is also expensive. It's not that expensive in a way if you are saving a life. But it cannot, it might not be affordable to have it in all places and to be available, and to be available in 1 minute. And it has to be distributed over a big area. So even starting CPR in the beginning as early as possible, it can make a difference also in the life of the person. So yes, I agree. So you have these three, and this is very important. Yes.
Thank you, Dr. Mona. I just have a question. What about the maintenance of the AEDs? I mean, what kind of expenses are there?
Usually, they don't need a maintenance per se, and you don't need to maintain them like we do with medical equipment to come and check if they are functioning or not. But there is a life time for the battery. So you have to change the battery depending, and some every 5 years, every 3 years, depending. And you have also to have a new pad. So also the pad has an expiry date. So the pad that is used. So also you have this. So this is it. So in terms of maintenance, if you can say, it is just to know when is the expiry date and change it.
So how expensive is it? Let's go back to the basic.
How expensive?
How much is the price?
AED, it can range between 1,000, one AED, and between 1,000, maybe 500 up to 4,000, depending on what it is. So it is to a certain degree expensive.
It is expensive.
If we want to talk about it at the public health level,
especially for public schools and
for public schools, that's it. It is expensive, and you can have one in the school, for example, and know where it is, and have a response plan put in place, so you know where to get it immediately. So you can have, or maybe two, for example. But of course, it is expensive.
But at least at clubs, sports clubs,
of course,
they charge people. Okay.
We have a few more questions online, but I had a question also. What if we don't have access to an AED and the rescue is far away from us and cannot come to us? What's the solution in this case?
CPR. You start CPR immediately. You have to start CPR. Of course, first you have to call somebody. In a way. So you have to alert and call somebody, and you can start the CPR. Starting the CPR until they arrive. You cannot do anything else.
Okay, so we have a question from Dr. Mayjurdi. She says, thanks a lot, Dr. Osman, highly informative. Shouldn't we have ongoing training programs at AUB for a start? Also, on that comment, we have Amal Hussein, who also thanks you very much for this interesting talk. And I strongly agree with Professor Mayjurdi's comment that training programs are essential. In UAE at UOS, we have yearly training CPR programs for faculty and students.
Yes, no, I agree, Kamal. I fully agree. In fact, we had, again, as I mentioned, in 2019, we faced the economical crisis, the COVID, everything. So before 2019, Champs Fund, if I can say, with AUB, with Mr. Farouk Merabi, also with the Life Support Center, we're conducting also a lot of training for the staff. If you remember, I know we had 2 people trained from each faculty at that time on how to use that. This was at the time when the AEDs were put. So already this was done, and we're planning on resuming it. We have also an initiative with the USFC also to train students, because we want sustainability, in fact. So we're training a group, we trained a group of students who will be trainers and training of trainers. So they will be spreading the awareness among all the students at AUB. So we have this plan. Hopefully it will materialize. But I fully agree.
We also have two comments written from Dr. Wissam Dudar and Dr. Muhammad Nasser from UNRWA. They are saying that it is important to have these activities of screening and management everywhere, and having these AEDs at every institution, in malls, in universities and schools is highly recommended also.
True. I agree. Cool. Yes.
I checked the, thank you, Mona, for, again, a very interesting and very informative presentation. I checked the Lancet Commission, and in the title, they talk about a multidisciplinary need for multidisciplinary action. So can you elaborate on that in the context of Lebanon? What was planned and what is sort of the future plan for multidisciplinary, and where does policy fit into all of this?
Still, we did not reach really the stage of policy, if I can say. This is what we're still lacking in Lebanon. We did a lot of advocacy efforts, if I can say, before 2019, and the multidisciplinary, because this is not a doctor perspective only, it's not a nurse. So you have the healthcare system, you have the educational, you have the sports, you have the legal part. So this is the discussions started before 2019, and we are moving along, good lines. But I think it stopped in 2019 afterwards. That's why I put it in my take-home messages at the end. Really, this is what we need to do. To continue the action on the first steps that were done, really to have a policy for sudden cardiac arrest, to have registries, to have, you have a lot of things that you have to take into consideration. We have to have a registry. We have to have guidelines for that. We have to have, so that's why it's really a big multidisciplinary.
Things are things are much worse now. But even before the collapse,
they were not there yet. We were not there yet.
So what can you share your own challenges on trying to make the point of why this is important vis-a-vis all the other public health challenges in the country? What was your argument, and how could you push that through the Ministry of Education, Ministry of Health, Ministry of Education? Because realistically, or practically, not realistic, practically, there are too many other competitors from a good point of view that talking about cancer, talking about diabetes, talking about injuries and so many other things. And so how do you promote and advocate for something with low prevalence and maybe less public health significance than other things?
I can. It's more public. I'm kidding. First of all, I think because this is a tragical event. I think this was the main thing. We had several cases of sudden cardiac arrest among youth in Lebanon, and this was one of the arguments, and this was, I think, one of the main factors that really made, if I can say, decision makers at that time to accept discussing more this topic. The second one is the media. The media played a big role in that, because with the media highlighting really the catastrophe that's happening, the suffering of the the suffering of the family, the peers, the community, etc. This facilitated the discussion also, and sharing experiences, having evidence from other countries. For example, in other countries like in France, in UK recently, they adopted having AED in all public places. You have a lot in different countries, in Australia, everywhere. You have AEDs in all public places. So bringing this evidence and sharing this evidence with the decision makers helped. Of course, it helped having the memos, but it did not help going into the implementation, because in the implementation, you have a lot of challenges. You have especially financial challenges there because of the AED because of the training. Training is not for free. So you have also you have cost associated with the training. And again, as you mentioned, yani, yes, this is not as, the prevalence or the incidence is not as high, but yani, these are, that's why it did not move forward, I guess, more. Yani.
Okay, I think for the sake of time, we'll take one last question.
Yeah, but one thought on this, and it's very relevant. Are there statistics about how many lives were saved when we had this intervention installed? Because this could probably help the argument.
At AUB, we have it. Yes, at AUB, for example, we know how many lives were saved.
International, maybe probably bringing in some data internationally.
But this is it. This is I mentioned it. It triples the chances of survival.
Okay.
So it triples. Yani, you will increase it. At AUB also we had cases that survived. Even the last, I think, incident that happened also. Where AED was not used, but the student survived, luckily, alhamdulillah, yani she survived because they started immediately CPR and then they continued a good medical treatment. So, again, أصلاً كله بإرادة الله يعني بالنهاية, I think we can all say that, but of course it will increase the changes.
But I think this successful story from AED, the survival, this gonna incentivize at least the good organization that could afford to have the AED in place.
Of course.
So I just want to, just for the sake of time, any more questions online?
Just for the comment, said that we have an AED at NHPE.
Yes.
And last time we had to use it had a battery low.
Oh, so
Yeah, this is what I'm
okay. Maintenance.
You can use it. Yes.
Just sharing this to check.
True.
Okay. Yeah, it's important to be aware who's like part of this team just for the prevention.
Mahia, this is the incident that I mentioned in the medical school. I know, but at that time she survived. That's why I'm mentioning. I know they started immediately the CPR, but at that time there was this confusion. I know the AED were functional, the AEDs, but people did not know. I know they were functional, so they did not use it. So this is what happened.
Two stories from AED only. No, this is absolutely.
So that's why that story was when awareness was high, training was there, everything. The second story was after COVID, after Haida, where, that's why I said, you need to continue. This should be sustained. This also, this is associated with additional costs in a way. So that's why you need to create something that is sustainable with no cost. And that's why we thought with USFC last year, to train students, trainers who can really themselves spread this awareness and have more people on that trained.
All right. Okay. So thank you again, Dr. Osman, for
the
presentation. I just want to mention that we're going to be, Dr. Osman is going to continue. We're going to having a booth outside.
With a group of volunteers, I think that in front of you.
CPR training and AED also, and then AKG.
And EKG.
Yes. Okay. But thank you so much, and we'll see you next
time.
Bye.